Hello everyone. Today I'm presenting on primary skin B-cell lymphomas. Lymphomas can develop from either T lymphocytes or B lymphocytes, and B-cell skin lymphomas are skin lymphomas that develop from B lymphocytes or so-called B cells. And about a quarter to a third of all skin lymphomas are B-cell lymphomas. And the combined WHO and the European Organization of Research and Treatment of Cutaneous Lymphoma classification actually highlights indolent skin B-cell lymphomas and more aggressive types. In the indolent are a marginal zone lymphoma and cutaneous follicular lymphoma. Then we have the more aggressive types, which is the diffuse large B-cell lymphoma, leg type, which is of all aggressive the most common. And then we have also the diffuse large B-cell lymphoma other, which is not the leg type. We also have an entity that's driven by Epstein-Barr virus, which is usually in immune-compromised patients and can develop ulcerated lesions. And so, as you can see here, most of the indolent lymphomas, the survival here, what they looked, usually those two categories do really well. The aggressive types have a little shorter outcomes, the more aggressive, as hence it says, and there's no data out on the EBV-driven mucocutaneous ulcer yet. So the clinical presentation and symptoms of B-cell lymphoma. So they can present as a solitary lump, a cluster of several lumps, or rarely can be more widespread throughout the skin. And they can also look like bug bites, they can look like an infection, pimples, and even eczema. And it appears that head and back, shoulders, or leg are the most common areas that are involved. Some of the lesions can be asymptomatic, so patients don't even know that they have it, but some can be quite itchy or can be also sensitive or painful to touch. And sometimes we can actually even say the body site involvement is often characteristic or points out what kind of B-cell lymphoma we're dealing with. So the most common skin B-cell lymphomas are here listed. This is the follicular lymphoma. It's the most common. The prognosis is excellent. The marginal zone lymphoma is also common and has an excellent prognosis. Again, the diffuse large B-cell lymphoma, leg type, is the third common, less common, and has a less favorable prognosis. This is an example, and I just want to point out, this looks like really like almost like an infection, and the large lump of plaque actually involving the scalp. And when you do a biopsy, you can see here there are areas, it's a dense infiltrate, the areas who show little, which we call follicles of lighter cells, and they're surrounded by darker cells. And this infiltrate is basically mimicking something what you see in a lymph node. This is another lesion here, shows on the submandibular area, and this is more widespread here on the back. So the diagnosis, how do we make a diagnosis, and what is needed? So the diagnosis is really based on a thorough pathology review and some special stage, which we call immunohistochemical staining or immunophenotyping of a skin biopsy. And the diagnosis and appropriate staging procedures are critical to distinguish B-cell skin lymphomas from systemic B-cell lymphomas involving the skin as a secondary site, as treatments and outcomes may differ between primary and secondary B-cell lymphomas. This is here just an example, and I've shown this before. This is what we call follicular lymphoma, and this is called marginal zone lymphoma. Do we know this just by a glance? No, we don't know this, but often this is the most common presentation. With the marginal zone lymphoma, what you can see here in the skin, it's more tracing adnexal structures, like here there are some hair follicles and some glands, and so usually tracing down those adnexal structures, while the follicular lymphoma presents mostly mimicking a small lymph node in the skin, but it's not a lymph node, it's follicular lymphoma. So what we have to make sure that we, once we're dealing really with a lymphoma, that we're not excluding a bug bite reaction, that we're not thinking of a lupus or other autoimmune disorders, that sometimes a ruptured cyst or folliculitis can mimic, this infiltrate can be so heavy that it can mimic a lymphoma, but it's not. You can also have foreign body reactions, such as to tattoos or vaccinations or acupuncture that can, mimic a lymphoma. And there's infections. Certain infections can also have an exuberant inflammation, shingles, herpes infections, Lyme disease, inflamed warts, and even Helicobacter pylori actually can lead sometimes, which is more inside in the stomach, but can also lead to skin rashes. And then we have the true pseudolymphoma, which is the most difficult to distinguish from a true lymphoma. This is a so-called what we call pseudolymphoma, often in younger patients, often following trauma, like a pimple, and someone was just manipulating this over time and develops like a big, lump on the cheek. It's most commonly in the head and trunk, face, ear, nose, forehead, nipple, scrotum can be involved as most common sites. It rarely recurs, so usually once you're taking care of that, so it disappears. What do we need to make a diagnosis of a primary skin B-cell lymphoma? So first of all, we need the medical history, and you're critical in that. So if you can really memorize everything that pertains to the lesion, this is very, very helpful for us. Then the symptoms, whether it's itchy, painful, or not at all, then we give usually a physical examination, including a total body skin exam. And importantly here, we need to take full thickness skin biopsy. This has to be full thickness through the skin because sometimes the lymphoma can be a little deeper. And if you just do a superficial shave biopsy, you may not capture everything. We also do blood tests, which would include complete blood cell counts, a comprehensive metabolic panel, and something that's called LDH. That's the first panel. And then serology for potential infections and autoimmune markers. Whole body imaging scans could be either PET-CT scans or CT scans alone. The bone marrow biopsy here, I'd like to point out, is required really for something we call diffuse large B-cell lymphoma, but it's optional for the other subtypes. And in the clinical reality, less and less performed, and just mainly here based on the aggressiveness. Additional tests I like to point out, this is what we include, is an ANA antibody titer, which actually shows whether patients may have a history or the immunity. And Lyme titer. In Europe, and there have been historically cases that have been linked to Lyme disease, but in recent years has not been really found, but still we're doing those tests. And Helicobacter pylori test, which is important, hepatitis serology, and also including in certain instances syphilis titer, which can sometimes mimic even a B-cell lymphoma. what the research has found, and this is one of the centers in the United States, what they found actually that a lot of these cutaneous marginal zone lymphomas are associated with some problems, GI problems, in 2/3 of the cases roughly, and also with autoimmunity in roughly a quarter of the patients. So what they found actually, some patients have autoimmune thyroiditis, they have lupus of Sjogren's syndrome, and elevated ANA titers. These are autoimmune antibodies. This is an example here, what I'd like to show. This is follicular lymphoma, often found on the head and neck area, usually presents as a solitary or multiple lumps on head and trunk, and mainly the back. Frequent skin relapses, and it's low risk to spread beyond the skin. This is a marginal zone lymphoma, or called malt lymphoma. More commonly seen in young patients, can present as a solitary or clusters or multiple lumps. Often here, what we see here on the arms and legs in Europe has been found, as I mentioned, to be associated with Lyme disease. Patients do frequently relapses, like seen in the follicular lymphoma, in about roughly half, 40–50% of patients. Very low risk to spread beyond the skin, and high incidence here of autoimmunity and gastrointestinal problems associated with it. This is an example here, diffuse large B-cell lymphoma, leg type. These are more older patients, and it's more seen more commonly seen in women compared to men. It can present as a solitary or multiple lumps, as you can see here. Here in this lower, you can see both legs are involved. In this patient, only one leg was involved. They also frequently relapse and frequently can systemically spread. The prognosis is less favorable compared to the other B-cell skin lymphomas. Are there any molecular alterations of cutaneous B-cell lymphomas that can actually help with the diagnosis? And so there are certain things, like, for example, in cutaneous follicular lymphoma, there is lack the translocation that involves the BCL2 gene. So this is generally negative, and compared to the systemic follicular lymphomas arising in lymph nodes, just in general. In cutaneous marginal zone lymphoma, what you find actually, there's common translocations involving IgH or MALT1 gene. And MYD88 mutations and MYC rearrangements have been found in large B-cell lymphoma leg type, but this is also found in some of the systemic diffuse large B-cell lymphomas. And while this is very important in testing, it is because it links to a specific activated B-cell type. It cannot distinguish between primary cutaneous or primary skin compared to systemic. More recently, in the cutaneous follicular lymphoma, the genomic studies have provided and have shown a link that between this lymphoma to other lymphomas of other anatomical sites. And this may be interesting also to see whether some of those genes or that have been seen in those follicular lymphomas can actually predict spreading internally. But yet the data are very small, and we have to really probably wait and get longer observation periods. So what's important is the histopathology diagnosis is the most important prognostic determinant. And so, again, as I mentioned, we have the low-grade lymphomas, follicular lymphoma or marginal zone lymphomas, and this needs to be distinguished from something that's called diffuse large B-cell lymphomas. Both follicular lymphoma and marginal zone lymphoma are low risk and rarely spread to internal sites and have an excellent prognosis. The diffuse large B-cell lymphoma leg type is a high-grade lymphoma with a less favorable prognosis. So the treatment principle, and because the prognosis is, of course, that guides us to treat and how to treat. And often in this low-grade B-cell lymphoma, which is the marginal zone lymphoma and the follicular lymphoma, which may, if this often we can treat actually with an antibiotic first and get actually often sometimes those B-cell lymphomas actually in remission or halt actually from further growing. And both types, follicular lymphoma and marginal zone lymphomas, are essentially treated in the same way or similarly. A single lump, you can watch it, you can have intralesional steroid injection, you can have it excised, or you can have localized radiation therapy. If you have a small cluster of lumps or a few other areas are involved, you still can watch it, and you can still give intralesional steroid injections or have radiotherapy apply to that. If it's really more widespread and it's really bothersome and often more and more lesions, popping up, and so there's a systemic therapy, which an antibody, which is called rituximab, which works in B-cell lymphomas and can be used in selected instances. So the high-grade skin lymphoma is really the one that needs really attention and needs to be treated. There's systemic therapy. This can be given either in combination alone or in combination with radiotherapy. Often patients are also treated on immune therapies or CAR T-cell therapy, which is still in clinical trials and clinical investigations, and most institutions have those options available. And those patients are treated similar to the systemic high-grade lymphomas. So here again, we have all these treatment listed. This is for the, we can have observation, excision, antibiotics, local radiation, intralesional interferon alpha, intralesional rituximab. We can have the systemic multi-agent chemotherapy, which is R-CHOP-based. This is really, as mentioned, for aggressive disease. Radiochemotherapy, the combination. We have clinical trials. We have topical steroids or intralesional steroids. We have photodynamic therapy and can have even chlorothamine gel. So these are all options we can use. It depends on the diagnosis. And so when we look, actually, this is based on data who's looked actually into summarize those data. What is there any treatment that's better than any other, but or does it prevent from relapses? And when you look actually all these treatments listed, none of those treatments actually prevent it from coming back. So there is actually a higher risk of relapses in of all of them, and they're roughly around 40-50%. Some of them have a lower recurrence rate here, but they have only very few patients treated. So roughly, you have to be prepared no matter what. So relapses are common, but which is not really bad, because you can also, treat again. And what I want to point out here, then in the primary cutaneous diffuse large B-cell lymphoma, this is really where we have to treat. We have to really, as a multi in a multi-team effort. And here's a summary. What patients presenting with, as I mentioned, can be a single lesion or can multiple lesions, most commonly on the legs, but can also present on the other body sides, even on the back. Usually, because it's a B-cell lymphoma, it's CD20 positive, and can have other markers like BCL2, CD79A, BCL6, and MUM1 and FOXP1. These are markers what we like to see. Frequent relapses and frequent spread to inside the body. So there are some other abnormalities here, but the survival is about 50%. And as you remember, in the low grade, they were above 90%. So it's a difference. And so that's why we really need, a more a treatment that actually works and for this more aggressive disease, and it's a systemic therapy and in combination with radiation. So there are several distinction actually to be made. The diffuse large B-cell lymphoma can be a germinal center B-cell-like or an activated B-cell-like. And this is now requested in the classification, and this is mainly based on which cell type, and this is here. This is the schema of this is what we see in the skin, and there are several subtypes of B cells, and the distinction is made where it derives from, but it's important because it may actually affect outcomes as well. The diffuse large B-cell lymphoma leg type comes from an activated B-cell phenotype, and again, as I mentioned, it's now this workup is now mandatory actually in the diagnosis. This is something I'd like to show. This is the tip is another lump on the foot. You can see those sheets of cells are large, and they're also expressing here MOM1, which is a feature of these more aggressive large B-cell lymphomas, including the leg type. It's not a feature of the skin type, but it's a feature in general of the diffuse large B-cell lymphomas. So this is just a comparison here, and what I have mentioned, certain body sites are more involved than others by the specific types of lymphomas. Marginal zone is usually the extremities, younger patient. Follicular lymphoma is usually on the head and trunk. Older patients, diffuse large B-cell lymphoma leg type is usually on the legs, can also rarely involve other body sites, and is seen in older patients and predominantly seen in female patients. Here are some markers that helps distinguishing one from the other, and which is important, and most all of the hematopathologists or pathologists will use those markers to identify the specific type of the lymphoma. The 5-year survival here, which shows here the patients here again in the indolent, they do very well. The leg type as a mixed, so hopefully with newer treatments in place, so this can also improve the survival, and that's the goal what most centers have. So this is something I'd like to point out. Often what I see here, and sometimes here in our center, if you have something, a lot of the chronic lymphocytic leukemia is I think in most instances, a chronic but more slowly progressing leukemia, and often just watched in centers. Sometimes those leukemia cells can really live in the skin, and they can mimic a cutaneous marginal zone lymphoma. And that's just doing a biopsy alone really will not lead to the diagnosis. Hence, this is very, very critical that we always check blood work and scans. And in the blood work, actually in the workup, we will come to the diagnosis. And it's like a puzzle putting things together. Again, this is something here. This is just a histopathology. This is a deeper biopsy, which shows really these follicles with those one follicle after the other, mimicking a marginal zone lymphoma. But this is definitely those smaller cells here. This is really leukemia, chronic lymphocytic leukemia. So that's why it's important. Actually, we have for the first line is usually the dermatologist, and he works closely with the dermatopathologist. And it's critical that, your treating doctors actually also know about primary and secondary skin lymphomas and do the appropriate workup. And if you find, you also have to have those doctors, discussing the findings with the clinical oncologists, on a healthy dialogue between all team members. And team effort is, I think, ultimately the best for our patients. So this is, now I'm reaching the end of my presentation. I hope I wasn't too fast. Thank you. Thank you all for listening. Thank you also for the Cutaneous Lymphoma Foundation for inviting me. And I have an email. I'm sure you are have wonderful doctors. And just in case if you have questions other than that, thank you.
Good morning and welcome, and thank you so much for joining us, Dr. Querfeld, and for that amazing presentation this morning. Just as an introduction, Dr. Querfeld is an associate professor in dermatology and dermapathology and a member of Beckman Research Institute at City of Hope. She is the director of City Hope's multidisciplinary cutaneous lymphoma program at Tony Stevenson Lymphoma Center. She's one of the world's renowned expert in diagnosis and management of cutaneous lymphomas. Her other areas of expertise include dermapathology with a specialized knowledge in diagnosing melanoma, cutaneous lymphoma, as well as other skin cancers. We so appreciate you being here with us, Dr. Querfeld, and look forward to having you answer some questions from our audience.
Thank you.
Good morning, Dr. Querfeld. I'm just plopping in to ask the questions. So good to see you, and thanks for joining us so bright and early in the morning. I know it's early hours out there on the West Coast, and sorry about some of the technical challenges, but so I'll just ask everybody, if you can put your questions into the Q&A little tab, and to kind of kick us off, I know a lot of people have concerns. You've been treating cutaneous lymphomas for a very long time, and all the variations and all the rare variants. And we get questions frequently about the cutaneous B cells. Gosh, why can't I do some of the other therapies? And in your presentation, you really talked about what's available and how we can really manage many of the B cells. Maybe you can speak to how you work with the patients that have B cells to decide which is the best treatment path for them at that point in time, and then maybe how that might change over the course of their experience with the B cell, depending upon what may be happening with their disease. That makes sense?
Yes. Yes. So absolutely. So what I usually when most of the most common, as I mentioned in the presentation, are really the follicular lymphoma and the marginal zone lymphoma. And it really turns out that marginal zone lymphoma is in younger patients. And I say young patients when we are all under 60, and a bit older is when we are over 60. But much younger patients are marginal zone lymphoma, and they are, around the age of, I would say, between 20 and 40, what I see in the majority of my patients. So, and patients who follicular are a little bit older in age. But, what's critical, we have to make sure that we are really establishing the diagnosis. And sometimes I do a rebiopsy. I do also the laboratory tests. And for sure, for follicular lymphoma, I do scans. And sometimes also for the marginal zone lymphomas. So the reason is we have to first establish that this is only cutaneous. And if it's only cutaneous, and we say, then we're in a good spot. And so then we can choose, and we can also wait. And if patients, when I say my patients are not anxious, and say, well, I'm not bothered by it, it's very tiny, we can even watch it. I often tend to inject it with injection with steroids. It goes away. It stays away. If it comes back, we can do this. We can watch it. Sometimes I give, as a first line, if many lesions, I give antibiotics. And so I work with the patients. I have to also got to know what the patient wants. And so I appreciate if the patients tell me. And if the patient is sometimes, very anxious about the diagnosis, I said, okay, so we want to get rid of it right away so that you're not remembered and seeing it. And but I want to make sure that everyone understands this is a very, very indolent. These types are very, very indolent, and we we don't need aggressive treatment. However, over the time, it can relapse, and so we have to make sure that we follow I want to follow my patients closely. So I usually say initially every 3-4 months. If it all goes well, then 6 months. If really nothing comes back, once a year is okay. Still, after many years, it could come back. And doesn't mean if it comes back, it's more aggressive. And if sometimes patients have lesions all over the body, still this is not too concerning. If it's really bothersome, we could consider infusion therapy with Rituxan, but in general, it's very localized. There are a lot of mimickers too, which I haven't really touched on this presentation. And so we maybe can in the future update a presentation, but for example, bug bites can mimic a lymphoma. We want to make sure that it's not a bug bite we're over treating and over killing. But there are also sometimes other hematologic cancers that's called, for example, chronic lymphocytic leukemia. And it's often not recognized because no blood tests are taken and patients are asymptomatic. And then they show up in the skin first, and it can be misdiagnosed as a marginal zone lymphoma. That's why blood tests are very important. That's why CT scans or PET-CT scans are also very important. So a thorough workup is very critical.
That's very good to know. And I think, one of the other questions then is a couple questions, but once I'm diagnosed and we've got a treatment plan in place and we've got kind of our structure, how often and what kinds of testing do I need to do? Or is it something that you can monitor with, a specialty physician that understands the disease, of course? Do you need to do recurring imaging scans, or is there blood work? People ask about those kinds of things, like what should I be doing to make sure that I'm staying on top of this? Are there annual tests that I should do, or can I be comfortable knowing I'm being seen by a specialist and we can manage from there? What's your recommendation on that?
Yes, it's that's a very excellent question. And so initially we have a very thorough workup. So we check really for all blood counts. We check specialty tests to check for infections, for autoimmunity, and we do scans. However, if the scans are negative and then we don't need to repeat, or we don't repeat unless there is some concern, unless patients develop really a swollen lymph node, or we should really check. But it's not like we need to do scans every 6 months. Second, the blood tests. So we don't need to repeat all the blood tests all the time. But at minimum, we do a minimum panel, which is complete blood cell counts, maybe immunoglobulins, comprehensive metabolic panel and LDH. This is a minimum, and we can actually check on those tests, how you're doing inside. And that's relevant. There's no specific, this is just in general a test which we would do for other lymphoma patients who have systemic lymphoma. So this is, however, I think a workup we recommend every year. We don't need to do this every 6 months or every 4 months. I see patients, they see their physician every month and they get the lab checked. But if the skin is clear and you're doing well, you don't need to check on such a frequent basis. So other colleagues may do it more frequently. So it depends on the center, and but you don't need to. The most important thing is really to have a check, a skin check, I think. And if something is worrisome in between before you schedule, you should seek advice. But a blood test in the skin can sometimes, like if you have elevated immunoglobulins or specific, or electrophoresis, which is a test that checks for certain proteins in the urine. This is something. If something is abnormal, yes, then we should follow this over time.
Mm-hmm. So it sounds like what's very important is that initial workup, so that you've got a good baseline for monitoring. What would your thoughts be or recommendations for patients who may not live near a specialty center, where they either may have to travel to a specialty center like City of Hope, or maybe their physician can consult with an expert? It's just impossible to travel. Do you have, this is probably a loaded question, because I know that the clinical community in cutaneous lymphomas is very collaborative and willing to work with other clinicians, especially for patients who are geographically unable to get to a center. Do you have any thoughts on that, or recommendations for patients who are listening that might be able to, that can't get to an expert center like yours, and how they might build a connection or a collaboration with their physician and an expert?
Yeah, I think it's we do this very often because some patients come there far, and ideally, if patients could come once a year, or initially this would be to establish that we have seen the patient, that we know what you're dealing with. Then we always, we like to communicate with their doctors, and we are fine if the doctors continue the treatment, and they usually appreciate, input. And so it's only to make sure that our patients doing well. So I think once a year, if possible, initial visit would be good, so that we can establish. We can also now, with in the times with communicating with the physicians by phone, or we can also even have Teams. This is all actually it's all okay. I think now with the virtual, or with the medicine that comes into place, it may be easier, because then you can actually meet through those virtually. You don't have to come in. However, a skin exam still has to be done, in real time. But we often do this, and I think it works out best for the patient. So if also the doctors have questions, they can also reach out to us. So I think and this would be fine. And if really, because they can always give the treatments. This is not a specialized treatment that's not available in practices. So we all work together. So I think it's just like having created a safety net, so to speak. And then, we can all chime in.
That's great. I think that's so comforting for patients, because when you have a rare disease diagnosis like this, but you're in an area where there are no experts geographically located, or, you can't get to a center, it can be even more terrifying, right, after you get that diagnosis. So I think it's very comforting for patients to understand that there is help for them and for their physicians to get that kind of expert collaboration. And I'll just make mention for maybe some of the folks listening that we have the listing of the expert treatment centers on our website. So you can look by state, by location to see which center might be closest to you, and to be able to establish that relationship. So I think that's, at least from my perspective, very comforting to know that no one really has to be left out there by themselves. Alone. And if you have some more questions for Dr. Querfeld, we have a few more minutes before our session ends. Please put them into the Q&A box. And oh, I had another question. I know what I wanted to ask you. You are very deeply into the research in cutaneous lymphomas. And I think one of the challenges is when you have the rare of the rare, like the the cutaneous B-cell lymphomas, often they don't get as much focus sometimes as the bigger bucket of the T-cell lymphomas. And also, I think because they tend to be, we're able to treat them a little bit easier is probably not the right term. And I don't want to offend anybody who's living with cutaneous B-cell because that's challenging as well. But do you have any thoughts on what some of the research might be pointing to, or some things that I know you mentioned in the video using imiquimod, and some of the other therapies that are available in different ways. Do you have any insights into what we might be learning about the B cells, the cutaneous B cells?
I think yes, Susan, great question. And so the research has been a bit hampered by the fact that B cells are rarer than the T cell lymphomas. And in terms of research, so there's actually a new data out that shows that in follicular lymphoma, there is a subset of patients who do have very minimal, but who can develop later on spread inside. And so there may be a gene signature that they can predict early on as to why these follicular lymphomas spread into lymph nodes, and can be distinguished from the ones who are systemic and can be distinguished from the ones who stay in the skin. So that's quite interesting. There's nothing in terms of marginal zone lymphoma. People, experts, researchers have sequenced and have done some molecular analysis. So there's no specific aberration found. So it's very hard to actually develop or look for a biomarker in this regard. So in terms of treatments, there are immune checkpoint therapies, new targets developed, but it's mainly for diffuse large B-cell lymphoma. And in all essence, this is the lymphoma where we have to focus. This needs more attention and really treatment, because this is, according to data, is not indolent. So it's more serious, but it can be also not super aggressive. So we have to really choose the right treatment. For sure, we want systemic therapy or combination systemic radiation therapy. This is different compared to follicular lymphoma and marginal zone lymphoma, clearly. And there have been new treatments, immune checkpoint therapies, biologic therapies. This is now developed for a lot of cancers. And I think this will be the future. Still, the chemotherapy is still a mainstay in this entity. Hopefully, over time, we can spare that, and we have immune therapies that are better tolerated, and actually other targets that really targets the molecular aberrations in this diffuse large B-cell lymphomas. Most of my research, most researchers in the cutaneous lymphoma world focus on T-cell lymphomas, but there has been done some research, and this is a good thing. Yes.
Yeah, thank you for that. One last question before we let you go. So if I'm the patient and I've been diagnosed with cutaneous B-cell lymphomas, and I'm preparing for my visit with my physician. Maybe it's my second visit after I've had the initial diagnosis, where I don't remember half of the things that were said, right? Now I've had a chance to do a little research, and they've been out on our website and they've learned a little bit. What would you suggest the kinds of questions they might want to have and ask their physician? What, from your side, what kinds of things do you want to have a conversation with your patients about, that they can be prepared so that the visit can be as impactful?
So prepared first to make sure, is the diagnosis, is this cancer? I mean, so sometimes the pathology reports are very vague when someone reads it. So this is and I get patients referred, and patients don't know exactly what they have. So ask, what does this mean? What is the diagnosis? Okay. So first of all, cancer, non-cancerous. Then what type is it? So if it's cancerous, so what type of indolent B-cell lymphoma? So then what subtype? This may not be that critical, but if you hear it's an indolent B-cell lymphoma, so you're in a good spot. Then can I get cured? Is the treatment, or is treatment available in general? So this is the most important. And then what's my overall, how do I get prepared for my life? Is this something I have to deal with throughout my life? Is it coming back all the time? These are good questions you need to prepare. And so the critical point is that patients don't know exactly what they have when they come to see me. And we are a tertiary referral center. And so we are not making the diagnosis often, we're getting them referred with a specific diagnosis. And so while I see the pathology beforehand, patients come, and then I know, okay, this could be this and that. So then when I see the patients, they're not exactly sure. And so I think this is a critical point, to discuss the diagnosis first and not assuming. And I think sometimes we all assume patients know things, but we don't know. And I've been a patient too, and I don't know everything. So that's how it is, and nowadays, and it's very important. So, and important to know what's your life going to be, and then you can prepare accordingly.
Great answer. Thank you so much for joining us this morning. We apologize again for the technical difficulties, but I think this has been so valuable, and we'll take you up on that offer to update the video. So perhaps sometime in the next year we can do another cutaneous B-cell webinar and do an update for folks. But
or we can, Susan, we can just streamline it. We just can put it or post it. That's fine too.
Yeah, we could just do a little add-on, right?
Yeah, a little add-on. Yeah,
a little add-on. I love it. It would be great. It would be great. Well, thank you. We so appreciate you taking the time this morning. I know it's very early out there on the West Coast, and but your expertise is always wonderful.
Yeah, thank you. I always, love working with you, Susan, with the team, with the foundation. I think I think also what I recommend to my patients, I said, if you don't read the internet, if you want to read something informative and it's true and it's approved, we go to the foundation website. And this is what I always give. I give them a little handout about their diagnosis, and then I give a handout about the foundation. That's my approach. So I think I'm also happy that patients communicate with each other. So I think this is very helpful.
Yeah, that's great. Thank you so much. And we look forward to seeing you again soon, and appreciate all of your expertise and your knowledge and your dedication to the cutaneous lymphoma patients. Your work over the years has just been so impactful, all of, not only just in the clinic, but in the lab as well. And what you've contributed to the field is amazing and greatly appreciated. So thank you very much. And we'll look forward to doing our little follow-up to your video.
Thank you. Yes, I look forward to it.
Great. Thank you, Dr. Querfeld. Have
Thank
a lovely
you.
rest of your weekend.
Thank you.
Thank you. You too. Bye-bye.
Okay,
Bye-bye.
Bye-bye.